All right, good afternoon, everyone. Again, my name is Michael Plazak. We'll be shifting gears pretty significantly now and talking about vasopressors and inotropes in some complex shock states with a specific focus on mixed cardiogenic and septic shock. Before we begin, I don't have any actual or potential conflicts of interest and related to the content in this presentation. However, we will be discussing some of the off-label use of medications throughout. So first before we go into a brief patient case to kind of help us highlight the difficulty in managing these patients, I want to discuss first some basic definitions as well as the epidemiology of circulatory shock states. Circulatory shock has a very high incidence in the ICU population, occurring about 1/3 of patients in a general ICU. And it's really characterized by the systemic hypotension as well as hyperperfusion of the end organs and hyperlactatemia. We can categorize circulatory shock into four main categories, such as distributive, which encompasses both septic and anaphylactic shocks, hypovolemic shocks, which is due to volume loss, and cardiogenic shock, which is usually secondary to acute myocardial infarction or acute decompensated heart failure. And lastly, our obstructive shock cases, which are usually secondary to a pulmonary embolism or cardiac tamponade. Now, all these together account for a mortality in excess of 40%. But the real question is, what happens when these shock states are overlapping? And we really don't know the answer to that in terms of the prognosis for the patient as well as how we can effectively manage them. So to help us highlight some of these key concepts, especially with the hemodynamics, I'm going to go through a patient case. This was an actual patient that was admitted here at UMMC, and it really helps highlight the complexity of all of this. She was a 57-year-old female who came in initially for the management of wet gangrene at Midtown. And on the day of her discharge, she actually ended up developing a non-ST elevation myocardial infarction, which is complicated by significant hypotension requiring the use of norepinephrine for vasopressor support. She was then transferred emergently here for a left heart and right heart catheterization. And when she actually got here, they found out that she had a significant leukocytosis as well as a high temperature. So when they did the left heart catheterization, they did find that she still had some residual multivessel disease, but they weren't able to intervene on anything there. And they went on to do a right heart catheterization looking at the filling pressures in the respective chambers of the heart. I have provided some reference ranges for you, but to just highlight this briefly, when they went in and inserted the pulmonary catheter, they found that she had significantly elevated right-sided pressures indicating volume overload and backup. This elevation persisted in the pulmonary artery as well as when they wedged that catheter into one of the smaller pulmonary arterioles, which gives us these elevations in this pulmonary capillary wedge pressure are indicative of left ventricular failure and volume overload. Now we can also look at the cardiac output and the cardiac index in these patients, which is a marker of how well we are effectively pumping blood out of the left ventricle. And they found that she also had reductions in her cardiac output, likely secondary to all this volume overload in the setting of this NSEMI. Another parameter that's important to consider throughout the rest of this presentation is something called systemic vascular resistance. And this is the true left ventricular afterload, or the pressure that the left ventricle has to pump against every time that it beats. In her SVR was actually elevated, which is probably more indicative of her being on a vasopressor agent. But we do see that she has reductions in her cardiac output. So now we have a brief idea of what we're going to get into during this. I would like you, by the end of this presentation, to be able to first compare and contrast the pathophysiology and hemodynamic parameters that we see in the various circulatory shock states. Also to evaluate the available vasopressor agents as well as some of our true inotropes through recent literature review as well as the pharmacodynamic and toxicity profile analysis. And lastly, be able to design an evidence-based therapy regimen for this patient presenting with a mixed cardiogenic and septic shock picture. So I've already gone over SVR, cardiac output, as well as CVP is a marker of that right atrial pressure. So we saw in her that it was elevated. And this SVO2 is our mixed venous oxygen saturation, which is a marker of really the oxygen utilization of our tissues. And this percentage is indicative of the percentage of oxygen in the hemoglobin when it's returned to the right side of the heart. So looking at these individual markers, we see that in our cardiogenic, our hypovolemic, and our obstructive shock cases, they're really characterized by an initial insult to the cardiac output. So this reduction in cardiac output leads to a compensatory rise in our systemic vascular resistance as our body tries to continue to basically perfuse our end organs. On the end, and contrary to these, in distributed shock states like septic shock, we see an initial insult to the periphery where we see peripheral vasodilation from inflammatory cytokines, and then a rebound or a compensatory increase in cardiac output as we try to perfuse. Our focus today is really going to be on this distributed and cardiogenic picture, and it's really unclear what the clinical implications of that are in a mixed shock state. We don't really know what hemodynamic parameters are really dominating without the use of a pulmonary arterial catheterization. And so at this time, I will ask you to play Slido. Knowing that this patient has a reduction in cardiac output, during rounds the next morning, the medical team turns to you to provide them a recommendation regarding which additional vasoactive agent to utilize because this patient has a reduction in her mean arterial pressure to 61 millimeters of mercury, and they would like to increase it to 65 at least. So what do you recommend in this case? So not many people are confident here. Okay, so I have several answers. We'll come back to this at the end of this presentation to see if your opinions change. All right, to first go over the mechanistic implications of all the agents we have to our disposal, I want to orient you to this figure right here. So starting with the colors, as we increase in darkness of this green, you have increases in receptor affinity and activity at these receptors. Going from left to right, the alpha-1 receptor, activation of this receptor results in peripheral vasoconstriction. The activation of alpha-2 is more of a inhibition of norepinephrine, endogenous norepinephrine release, and really won't be the focus of this presentation. The beta-1 activation will result in increases in chronotropy, which is an increase in heart rate, as well as increases in inotropy, or increased myocardial contractility. And then increases in the activation of the beta-2 receptor will result in smooth muscle relaxation, which is really characterized by bronchodilation as well as some systemic vasodilation. And then lastly, the dopamine receptor, dopamine 1, it really is involved in improvements in renal perfusion as well as splanchnic perfusion. Traditionally, dopamine has been categorized into 3 distinct dosing categories, termed low dose, medium dose, and high dose dopamine. And it's really thought that at these lower doses, we see mostly activity at the dopamine receptor. And as we increase the dose to the medium threshold, we see more activity at our beta-1 receptors and more increases in cardiac output. And lastly, as we increase the dose beyond 10 mics per kilo per minute, we see increases in our alpha activity, which corresponds to increases in vasoconstriction. Epinephrine has similar characteristics in that it's very dose dependent. At our lower doses, we see more activity at our beta-1 receptors, but you can see it's more spread out among the alpha as well. And as we increase our dose, we see more activity at our alpha, providing more vasoconstriction. Norepinephrine, on the other hand, has most of its activity at alpha-1, which results in vasoconstriction in the periphery, but we do have some preservation of that beta activity and inotropy. Phenylephrine is a pure alpha agonist, and that will result in just purely vasoconstriction in the periphery. And then vasopressin actually has no effects on any of the adrenergic receptors. Its effects are on vasopressin 1, vasopressin 2 receptors. At the doses we use here in the United States at 0.03 units per minute, we see most of the activity at vasopressin 2 receptor, which results in fluid retention. However, as you increase that dose beyond that threshold, you see more activity at vasopressin 1, which results in increases in SVR. Our true inotrope, dobutamine, has most of its activity at the beta receptors. So activation of these will result in increases in cardiac output. You can see some reflex hypotension with dobutamine, as well as some of this beta-2 activation, which can cause some peripheral hypotension as well. And then milridone's use as an inotrope in a mixed shock state is a little bit more controversial because inhibition of the phosphodiesterase 3 enzyme is really problematic in that it can cause some pretty significant peripheral vasodilation, which would not be ideal in a vasodilatory shock state. And so to summarize, I provided some of these examples for you of what we just discussed. Please note that some of these agents are dose dependent in terms of their effects. The most of our true vasopressors will result in increases in SVR, and our true inotropes will be more likely to cause decreases in SVR. In terms of the cardiac output, we see for the most part the agents that we'll be discussing today, dopamine, epinephrine, and norepinephrine, will increase your cardiac output, and so will the true inotropes. Now, phenylephrine is a true alpha agonist, and this can actually increase your ventricular afterload, and could potentially result in decreases in your cardiac output. So its utility is not that great in someone that has a potential cardiogenic component here. We will no longer really discuss that. And then vasopressin's role in retaining fluid might be problematic as well, but we'll discuss this more. And so using vasopressors in cardiogenic shock, I just mentioned that there's potential for alpha activity and increases in afterload. And that can be problematic because we could see a decrease in cardiac output. So it's really important as we go through this that we're balancing our inotropy as well as our vasoconstriction. Secondly, the catecholamines that we'll be discussing can increase the myocardial oxygen demand and therefore develop this supply-demand mismatch and potentially lead to ischemia in the myocardium, which could be problematic for these patients. And lastly, all the catecholamines have some risk of actually being pro-arrhythmic, so their utility really has to be balanced and their doses have to be monitored carefully. And so knowing all of this and mechanistically, the overnight resident decides to initiate dopamine for more inotropy, and because he read UpToDate and it told him that it can improve splanchnic and renal perfusion. How should we respond to this? So dopamine and this renal perfusion theory this debate has been going on for a very long time. The DAD-HF trials, which were conducted in acute decompensated heart failure patients specifically, randomized patients to receive varying doses of IV diuresis with the addition or without the addition of this dopamine. And in this trial, specifically in DAD-HF2, they used 5 mics per kilo per minute, which isn't really that true low dose. But they showed that there was no difference in the worsening of renal function when they added on dopamine in this group. The Rose trial tried to build upon this a little bit by actually using true low-dose dopamine in the same population of acute decompensated heart failure. And again, dopamine did not improve their outcome of urine output. However, this trial is interesting to note because even at this low dose effect of dopamine, we see an effect on the beta-1 receptors, and there were actually increases in the rates of tachycardia in the patients that received dopamine, telling us that dopamine's effects probably aren't as cut and dry as we usually think they are. And it is important to note that mean arterial pressure and blood pressure in general are very complex hemodynamic parameters that take into account both cardiac output and SVR. And thus, if we're using dopamine and we see an increase in MAP, it's really unclear if that's because we increase their cardiac output or if we improve their SVR. So dopamine is a dirty drug, and the Ropodope trial tried to find a niche for it in the heart failure with preserved ejection fraction population and still found no effect of low-dose dopamine on renal perfusion. Lastly, and I think this is probably the final nail in the coffin for dopamine for our patients specifically, is that the SOAP2 trial, which was a trial in patients, all comers with circulatory shock, with the majority of which were distributive shock, randomized these patients to receive either norepinephrine or dopamine. And what they found is those patients that were randomized to dopamine had an increased risk of tachyarrhythmias, as well as in the subset of cardiogenic shock patients, there was an increased risk of 28-day mortality. And in our patient who has a potential cardiogenic component to her shock, this risk of actually increasing mortality is probably too great for us. And so knowing that the team understands the disadvantages of dopamine and we promptly discontinued the infusion, they are asking about alternatives that could potentially reduce her risk of tachyarrhythmias since she has this extensive coronary disease and this recent end-stemming. And vasopressin is a unique agent in this regard because it has no effects on the adrenergic receptors. It is not a catecholamine and potentially could reduce our risk of arrhythmias if we can reduce the dose of the catechols. The VAST trial was really the first trial that made vasopressin, showed the efficacy of vasopressin in a septic shock population. And they showed that with use of vasopressin, they could actually reduce the exposure of norepinephrine in the vasopressin group, as well as they found in the subgroup analysis, although controversial, that the use of vasopressin was actually beneficial in reducing mortality in the patients with less severe forms of septic shock. But they didn't really comment on the incidence of tachyarrhythmias in this population. And so there was a very small retrospective cohort study that looked at 71 patients with septic shock. And they found that the earlier that you start vasopressin, and in this trial they showed that if you start it within 6 hours of initiation of your other catecholamines, you can actually reduce the incidence of new onset arrhythmias in that early group. And again, they showed reductions in catecholamine exposure. Now again, this population is way different than the patient that we're dealing with because we potentially have somebody with cardiogenic shock. And the problem with all of this is that vasopressin's actions on vasopressin 2 receptor will lead to fluid retention, potentially overloading the left ventricle, and then potentially worsening this patient's shock status. And so the question is, what agents do we actually have that could potentially improve our cardiac output instead of potentially reducing it with vasopressin? And so that's where epinephrine comes into play. Epinephrine has a really interesting receptor profile in that we can achieve both inotropy, chronotropy, and vasoconstriction in the periphery based on its really broad receptor profile. It results ultimately in both increases in our systemic vascular resistance as well as our increases in the cardiac output. And theoretically, this mechanistic benefit would be ideal for this patient. However, there are several pilot studies out there that have looked at epinephrine in a cardiogenic shock population specifically. A group, the Levy and colleagues group, have looked at this pretty extensively and found that when they compared epinephrine alone to patients that received a combination of norepinephrine and dobutamine, they found that there were similar increases in mean arterial pressure and cardiac index when these agents were compared. However, the epinephrine group had increases in systemic arterial lactate as well as increases in heart rate and tachyarrhythmias and increases in something that they termed the cardiac double product. So cardiac double product is a product of both heart rate and systolic blood pressure, and it's supposed to be a surrogate marker for myocardial oxygen consumption. So what they concluded is that epinephrine has these metabolic consequences. However, the clinical implications and the prognostic implications of this increase in lactate and this increase in this cardiac double product or oxygen consumption are rather unclear. And so they went out and really what we're thinking about here is what is our balance with supply and demand in the myocardium and how can we really optimize that in these patients. And so they went on to conduct the recently published study Optima-CC, which was just published in JACC this year. And they randomized patients to receive either epinephrine alone or norepinephrine alone. This was a specifically cardiogenic shock population following an acute MI. And what they found was that patients that were randomized to epinephrine had a significantly increased risk of refractory shock. Although this wasn't one of their predefined outcomes, they terminated the trial early based on these results. And additionally, they found that there were still the metabolic complications that they found in their initial pilot study. And to finally summarize all of this, there is a systematic review out there of looking at epinephrine specifically in a cardiogenic population. They compiled over 2,500 patients with cardiogenic shock randomized to, or that received either epinephrine or some other vasopressor, including dopamine. And they found that epinephrine actually increased the risk of short-term mortality. When they adjusted for baseline characteristics and when they did a propensity score matching analysis, the result held true that there was an increased risk of mortality with epinephrine in somebody with a cardiogenic shock. And this is concerning in our population, in our patients specifically, because there probably is a component of cardiogenic shock to her. And so again, I will ask you to open up Slido. And I'll ask you the same question again based on what I've discussed with you mechanistically as well as the data that we do have, although limited. All right, so it looks like everybody is on board with using norepinephrine and dobutamine almost, and I would agree with that. I think that epinephrine or norepinephrine provides mostly alpha activity, so you can really titrate MAP based on both cardiac output and SVR by using the agents individually. One agent I have not mentioned thus far is angiotensin II. So this new drug is actually very interesting in a mixed cardiogenic and septic shock population, mainly for its mechanistic benefits potentially. So one, angiotensin II results in direct vasoconstriction of the peripheral arteries, and this will result in increases in SVR. However, you have to balance this with this potentiation and activation of our renin-angiotensin and aldosterone system, which will ultimately result in sodium absorption, reabsorption, as well as fluid reabsorption, which could be complex in a patient with a cardiogenic component and could potentially overload the left ventricle. But to balance that a little bit more is that angiotensin II actually has direct sympathetic effects and can actually result in increases in inotropy and chronotropy, which would be theoretically beneficial in somebody that has competing vasodilatory and cardiogenic components to their shock. And so angiotensin II thus far has very limited data, especially in our patient population that we're discussing today. But ACE-3 was conducted in a septic shock population, and they randomized patients who were refractory to catecholamine therapy to receive either angiotensin II or continue those catechols. And the addition of angiotensin II rapidly increased the mean arterial pressure compared to placebo within 3 hours of the start of that infusion, and again showed reductions in norepinephrine exposure, which could potentially be beneficial in helping somebody that's at high risk for arrhythmias. I think another interesting systematic review to consider with angiotensin II was this one conducted by Busey and colleagues. And they actually looked at all comers of shock that received angiotensin II, majority again though being distributive or septic shock states, but there were cardiogenic patients in this population. And they saw that initiation of angiotensin II resulted in increases in mean arterial pressure regardless of which shock state the patient presented with initially. So this could potentially be in the future a pathway that we could take in these patients, barring cost, of course. Something that's interesting though, and a mechanism that I did not discuss previously, is that there's thoughts that angiotensin II potentially has some benefit in the renal microvasculature. Angiotensin II causes direct vasoconstriction of the efferent arteriole and results in increases in GFR. And a recent post-hoc analysis was just published in Crit Care Medicine of the ATHOS-3 trial that showed that in the patients of ATHOS-3 that were receiving renal replacement therapies, the initiation of angiotensin II actually reduced 28-day mortality in that patient population. Now this is a post-hoc analysis, and we need to take it with a grain of salt, but it's something that we need to consider in the future, and future studies can really help us assess if there is a benefit here. And so I hope I imparted you upon all of you today that there is a fine balance between utilizing our agents that can increase our inotropy and chronotropy and thus our cardiac output with the effects of vasoconstriction. And we have a lot to balance and play with when we're looking at these patients' hemodynamics, and ultimately it comes down to how is the patient presenting and how do we best treat them with the agents that we have available. And so in the spirit of cardiology, I'll provide some of my recommendations and levels of evidence that I think is out there for this literature regarding management of patients with mixed cardiogenic and septic shock. So my first recommendation is that norepinephrine ideally should be a backbone vasoactive agent in patients that present with potentially mixed cardiogenic and septic shock states. I give this a class 1 level of evidence A recommendation. I think we have large randomized controlled trials in both a septic and a cardiogenic population to provide support for this recommendation, and norepinephrine really should be your first choice. My second recommendation is that I think it is reasonable to consider an addition of dobutamine if you know that the patient has poor cardiac output. Now, the easy way to get this information is with right heart catheterization, but in patients that don't have this available to them, we can use signs of end organ hyperperfusion to help guide this recommendation and when to initiate dobutamine. But we have to be careful in patients that have a very large component of vasodilatory shock, because we can actually potentiate that even more with dobutamine. I give this a class 2A level of evidence B recommendation. I think we need many more studies to suggest that this is going to actually be beneficial in this population. But the pilot data looks intriguing when we're comparing it to epinephrine alone. For my third recommendation, epinephrine may be considered as a therapeutic alternative to the combination of norepinephrine and dobutamine. I give this a class 2B level of evidence B recommendation. I think that the metabolic consequences of epinephrine are interesting. However, I don't know if those will actually translate over to clinical meaningful outcomes. We saw that in Optima CC there was an increased incidence of refractory shock with epinephrine use. However, that trial was stopped early and that outcome was not predefined previously. So it's something to consider when looking at epinephrine. But that systematic review did show increases in mortality in a cardiogenic population. My fourth recommendation is that vasopressin should be used cautiously and really reserved for patients that have refractory shock, or in those that we want to use catechol-sparing regimens because we have a worry of increased risk of tachyarrhythmias. And I give this a class 2B level evidence B recommendation. We have to be cautious with the fluid retention aspects of vasopressin in somebody that already has overloaded left ventricle. And lastly, the use of dopamine should be avoided in mixed cardiogenic and septic shock states. I give this a class 3 harm recommendation. The SOAP2 trial showed us that there is an increased risk of mortality in that patient population that has a cardiogenic component to their shock. And I think that the issues with determining what dose actually correlates to what effect is problematic, and it's easier to use two agents that have more specific effects and titrate them as necessary. And so with that, I'd be happy to take any questions. I confused you all. Yes, sir.
I'll ask one. So you mentioned a little bit about PA pressure monitoring and invasive hemodynamic monitoring, and I feel like in general there's a stigma that we don't do that anymore, but could you maybe talk a little bit about when that might be appropriate and when we might do more invasive hemodynamic monitoring?
Yeah, I think that this is a unique circumstance with mixed shock where invasive right heart catheterization is actually warranted. And somebody where you have two competing mechanisms of hemodynamic alterations, with one a septic component where you probably have a massive vasodilation, and two, you have a cardiogenic component where you have decreases in your cardiac output. And so I think without knowing where that patient really lies, that's where it warrants catheterization. Whereas in patients where we know what the hemodynamic effects are, it's easier and less invasive to just kind of use the therapies that are appropriate in that patient. So I think someone with more of a mixed state where we're uncertain of where they are hemodynamically, this is where it's more appropriate. Okay.
So question through Slido, it says, is there a dose at which you'd consider dobutamine as the backbone for mixed shock versus norepinephrine?
So I think that norepinephrine should be your backbone therapy, and you shouldn't initiate dobutamine without having it on board first, because you don't know where they are in terms of their peripheral vasodilation. So I think ideally you're starting norepinephrine first. You're seeing if there's any MAP improvement, and if you do see improvements in that, you know that it's probably more of a vasodilatory component. However, if you think that there's more cardiogenic nature to that, that's when you're considering adding on dobutamine. So once you're crossing thresholds of norepinephrine doses, probably in the 0.1s to 0.15 range, that's when you're considering this probably isn't working as well as it should be. Yes, Drew?
With the evidence we have so far, do you find any role for angiotensin II in your practice, and like what kind of patient would you use it in?
Yeah, so without access to it, no. I think that there eventually will be a role for angiotensin II. Right now, I think that the agents we have are decently effective in kind of managing it. We can titrate norepinephrine and dobutamine kind of simultaneously to see which one of them actually has the best effect. I think angiotensin II's mechanism is unique and that we could potentially see benefit in it right now. I just don't think we have anywhere near enough data to suggest that that's beneficial. We're really relying on ATHOS-3 and a lot of its post-hoc data to say that it's beneficial, whereas we have decades of experience with our catechols. Yes, Matt?
So let's say we got the MAP stabilized. Is there any recommendation on the order to come off of your agents? Like, should you take both off at the same time or one versus the other?
That's a good question. I would definitely not take both off at the same time. I think when you have the immunoarterial pressure is stable and potentially even elevated, I think you could start with one agent. And I think it's very patient specific. So if you think that their shock is more cardiogenic in nature, I would wean the norepinephrine first, and vice versa for if you think it's more vasodilatory and sepsis mediated. I think that it's more of a one agent first and see what happens. And if that doesn't work, you can try the other agent. But I wouldn't take both off at the same time. Thank you all.